The province is looking to redefine care for Ontario's aging population. After extensive consultations with 5,000 Ontario seniors, 2,500 stakeholders and more than 1,000 caregivers, the Provincial Ministry of Health and Long-Term Care has released its Living Longer, Living Well report, which sets out a strategy to make that happen. And joining us now with more, Deb Matthews, Ontario's Minister of Health and Long-Term Care. She's also the MPP for London North Centre. And Samir Sinha, Provincial Lead of the Ontario's Seniors Strategy and Director of Geriatrics at Mount Sinai and the University Health Network. Good to have both of you back here in the studio. Let's, you can say thank you or something like that.
Thanks. Great to be
yeah, great
here.
to be here. That's what I knew you wanted to say. Let's bring up this graphic just to get people up to scratch on what you folks have been dealing with. Here's our aging province. There are 1.9 million seniors in the province today. That's 14.6% of Ontario's total population. However, seniors account for nearly half of all health care spending. 14.6% of the population, but half the spending on health care. And it's expected that that number of Ontario seniors will double within 20 years. So this is the proverbial ticking time bomb that we hear so much about. And therefore, let me get you to start, Dr. Sinha, by telling us what the main recommendations of your seniors strategy are to deal with this.
I think the idea was that this report really thinks about aging as a challenge, for us, but really as an opportunity, because our healthcare system was designed at a very different point when people were often younger and needed very different types of services. So really this report was focusing on two main aspects. How do we help those older adults who have complex health issues? How do we support them to stay healthy and independent in their own homes as long as possible? But also, how do we also support more older Ontarians who are living well into longer age? How do we support them live long and happy lives? So the recommendations certainly do focus around healthcare in terms of improving our primary care system, the way we provide home and community care services, our long-term care services, but it also recognizes the social determinants of health. So thinking about poverty amongst older Ontarians, thinking about housing and transportation, because they told me that's equally important to them, but also making sure that our communities are elder friendly. So a lot of recommendations, but thinking in a comprehensive way of how we support older Ontarians in the future and currently.
Minister, these demographics have been not unknown to anybody for a quarter of a century. It feels as if we are kind of, and I don't say we Ontario, I mean the world, is kind of behind in getting there. How come?
So I would say that as our population has aged, and the population is aging now, we've added things like more home care and so on. But this demographic reality is approaching us quickly. And it's not like when baby boomers turn 65, all of a sudden they're going to need a whole lot more from our healthcare system. But as we age, we are going to need more and more. So I think our healthcare system isn't providing the best coordinated care today. So we got to get it right today, but more importantly, we've got to really transform the system so that it's providing the best possible quality of care and get the best value for our healthcare dollars as our population ages.
You went all over Ontario, right? You talked to lots of people. What was the #1 concern you kept hearing from people?
I think people really want to make sure that they have good access to quality care, and they want to make sure that all their health and social care providers are educated about their needs and they're talking to each other. So again, lots of great work happening in the province, but what we really worked on was understanding what have other jurisdictions done, what were some of the great ideas here, and how do we finally, for the first time in our history, actually have a comprehensive strategy to look at this population, which are such integral parts of our society.
I hear this all the time, that healthcare specialists, professionals, and so on don't have an adequate amount of training when it comes to gerontology or dealing with seniors. And it's a kind of, I don't know, this is a very unfortunate way to put it, but it's kind of, there's an ick factor, it's just not as sexy dealing with issues around aging as it is dealing with cardiology or brains or whatever. What do you do about that?
Well, this is an area that Samir has really focused on, because he is a gerontologist, he is a geriatrician. He understands the needs of older Ontarians, older adults. But if we're spending half our healthcare dollars on seniors, and most of our healthcare providers haven't had training in how best to care for seniors, that gives us an opportunity to do so much better, because training nurses, doctors, personal support workers, technicians, all of those clinicians is an important recommendation of that Samir has made to us.
Are they interested in this area of medicine?
Yes, they are. We haven't given them the opportunities, though, to discover how interested they are. So you look at our medical school curriculums. Samir can talk a lot more about this than I can, but we're not even exposing medical students and nursing students to opportunities in dealing with older Ontarians. So that's the first step. It wasn't very long ago that we thought doctors weren't that interested in going into primary care. That's changed totally, because now they're getting exposure to primary care and understanding what a fantastic career that can be. So I know this is a passion that Samir has expressed many times.
But not necessarily for very many other people, right?
Well, you know, this was the interesting thing. When we actually looked and we talked about our human resources in Ontario to meet the needs of an aging population, and it wasn't just, as I thought it was just the doctors that were not getting enough training in geriatrics. And then I met with the Ontario Nursing Association, the RNAO, and they said, Samir, nurses, social workers, personal support workers, they don't have curriculums that necessarily reflect, you know, how to care for older patients. So I'll give you an example. In our med schools in Ontario right now, everybody gets dedicated training in pediatrics, and lo and behold, we have the same number of children as we do the number of older adults, yet we have 10 times as many pediatricians in our province as we do have geriatricians.
Yes, those kids are fun.
Yeah, well, no, but I think a lot of, but you know, the OMA, when I met with the OMA, for example, around this issue, they said, you know what, our current practitioners are out there in the community and they're struggling to work and do the best they can with older adults because they don't have the training. So he said, could you support us through this strategy and making sure that we can actually get continuing medical education? And nurses and all the other workers were saying too, give us the knowledge, let us understand how to better care, because nobody wants to struggle in terms of caring for their patients. Everyone wants to deliver the best possible care, so we need to give them the tools to do that.
Deb Matthews, I want to show you a couple of charts here that I talked about, that ticking time bomb. I mean, here it is. This is what it looks like. Control room, can we get these ones up here? The future will cost us more. This is medical costs per age. And look at the bulge when we talk about seniors in the year 2030. That line just starts going right up to the heavens. And there is an enormous, what counts there as a $24 billion bulge coming in the not too distant future. And if we can, let's put the next graphic up as well. This is aging and hospital use. If you're a patient 70 years of age and older, this is what the future looks like here. Some people are going to be healthy. So you see that 42.6% of people who have no hospital episodes. But then you get a quarter who are consistently low users, and then high users and consistently high users when you're 70 and older. And this is where a huge chunk of our healthcare dollar goes. When you look at these charts, it is hard not to conclude that this is a beast that cannot be tamed, a day of reckoning that we somehow are just not going to be able to avoid. Is that the wrong conclusion?
It is absolutely the wrong conclusion.
How so?
And the reason it's the wrong conclusion is because we know we can, if we change how we deliver health care, we can get much better value for our healthcare dollars. When our seniors are getting care that's not coordinated, so they're getting care from a number of specialists, from their family doctor, home care providers, other supports, but nobody's talking to one another. We often hear about people, as our pharmacists are doing more reviews of medication. Different doctors have ordered the same medication, but different pills. So people aren't taking the right drugs. If we get better, and a lot better, at how we coordinate care, how we deliver integrated care to seniors, our cost per senior will decline. We will have more seniors. That is the reality. We will have more seniors, and that's a good thing. But we have to do a much better job of delivering much better coordinated care, keeping people out of hospital, keeping people out of long-term care if they don't need to go into long-term care. We have the twin challenges, I call them, demographics and fiscal, because there's not a whole lot more money to spend in health care.
Well, that's okay.
So we have to get better value, provide better care for people.
You're getting to my follow-up here, which is I see that $24 billion bulge, and my hunch is the Minister of Finance Ontario is not just going to hand you a check for $24 billion to handle this, so you're going to have to reallocate resources presumably within an existing system. Does that mean less money for hospitals, more money for out-of-hospital care, community care, that kind of thing? So
we've already embarked on that. So in the last budget, we held hospitals at a 0% base. We held physician at a 0% base, drugs at a 0% increase. all so that we could invest a significantly more in the community sector, focusing more on home care, more on respite care, so that caregivers could get a bit of a break. Those sort of community investments, we are making those investments now, and we're committed to doing it not just for 1 year, but over the next 3 years we can continue with that. So we're not cutting hospital budgets, but we're not increasing them either. But we are increasing significantly in the community so we can keep people home longer.
Okay. To that end, I want to touch on one of the relatively more controversial things this government has introduced, which is income-based home care. Can you just tell us how that would work?
So the first aspect was picking up on the minister's point here is that we have a demographic and fiscal challenge, and the idea we could say that cost, if we just do the same thing that we're doing right now, is going to be $24 billion, but we have an opportunity to do things differently. So Denmark, for example, what they did was when they were facing the exact same situation back in 1980, they shifted more home care to more home and community care. And by doing that, they were able to avoid building more expensive long-term care homes. They were even able to close hospital beds, for example, because people just didn't even need them anymore. So it's the idea of shifting to home and community care. So when we started talking about different ideas about how do we finance care for the future, how do we provide more home and community care, the minister said, if you're going to go and provide me recommendations, I want you to explore all the different possibilities out there, because this was a serious report. This was not an exercise in self-congratulation. So really there are three options. Right now, we know there are people who need more home and community care than can certainly get it right now. That's why the 4% increase is helping to actually meet some of that need, but there still is more need out there. And we know that in future, we're going to need more home and community care. So really, as far as I see it, we have three options, and this is what I spelled out in the report. One of those options got a lot of attention, and that was the idea of looking at what the majority of Canadian provinces and other OECD nations have done, is by creating an accessible and universal care system where those who need whatever care but who can't afford it will get it, and those who can pay a little bit can actually make a bit of a contribution. But the other options are there too. We might say, let's close more hospitals. Let's not have as many nurses. You know, we can make choices like that, which I don't think many of us want.
Okay,
and the other option is we could just raise our taxes.
Well, I was going to say, it sounds like you've given three options, none of which are particularly lovable. However, on this issue of income-based home care, Minister, I want to read you something here. This is from Natalie Mehra, who I know you know from the Ontario Health Coalition, who wrote the following. Universality is a core principle for health care. As more and more services are moved out of hospital, it is imperative that Ontarians insist that the Ontario government not abandon this principle in home and community care. The proposal to create a means-tested home care system explicitly threatens privatization rather than upholding the equity principles of the Canada Health Act when it comes to home and community care services for the elderly. Is she right?
No, I don't think she is right. I think that...
You guys are simpatico on so many things. Do you think she's wrong on this?
I think that the reality is, and your viewers will know this, a lot of people caring for seniors or seniors themselves do purchase a service now. So it's not like we have a 100% government-funded home care system. We don't.
Right.
So it's not that big a leap. I want everybody to get the care they need, to keep them out of hospital, to keep them out of long-term care, to have that care at home whenever possible. We've just recently, in the last budget, started income testing for drugs for seniors. So if you're at a very high income level, a single person, income over $100,000, a couple over $160,000, we're asking you to chip in a bit for your drugs.
What's the reaction to that been?
Nothing.
Come on.
Nothing.
Nothing?
Nothing. I thought that we would have real reaction. People are okay with it. People get it. They understand that. So the status quo is not an option. The status quo is not sustainable. So asking people at higher incomes to contribute a bit, I don't think is unreasonable, but I tell you, we haven't made a decision on it. It's not something we're moving on. It is a recommendation. It has sparked some conversation, and I think that's a healthy conversation to have.
But presumably, this is I mean, this is going to happen, right? You wouldn't be here talking to us about it if it weren't on.
Samir wrote his report independent of me. So these are his recommendations.
And the recommendation was to explore and to have a conversation. So the full report, you know, those who read the full report will understand that there were 5 principles that every recommendation adhered to. Was that we wanted to protect access, equity, quality, value, and choice. And the problem that we have right now with our current system that I pointed out was our community care access centers, they're strapped. And right now, you may only be able to get 1 or 2 hours if you're a low needs patient for services, and you may need a few more hours. So countries like Australia that just reformed their system that allowed, with a little bit more money coming in from those who could participate by having that, and BC and many other provinces have run the same sort of system, they allow people to get as much as they need, and those who can't pay at all don't pay anything. But those who can make a small contribution, and in British Columbia, for example, you can tax deduct any of those contributions you make to the system. So BC's been running the system for over 20 years. The majority of provinces have been running the system, and they actually have very effective home and community care systems as well. So the goal is, this is not a threat on universality. In fact, I think this actually strengthens it.
Well, let me give you the for instance. Joe saved his whole life, lived a modest life, has a little money in his retirement now, and as a result, because he meets that income threshold, he's going to have to pay a little bit extra for drugs. Sam, down at the other end of the street, lived a more profligate lifestyle, did not save as well, does not have as much money in the bank right now, and because he doesn't, you know, he's under that threshold, taxpayers are going to kick in and help him pay for his medicine. Joe is wondering how that's fair. What's the answer?
Well, I think part of this as well is that, I'll tell you, CARP, for example, the Canadian Association of Retired Pensioners, they've come out in support of this recommendation. They also came out in support of the recommendation around income-based drug testing, because you have to remember, this is not a recommendation, and again, this is a recommendation to explore, not necessarily to implement. First of all, we're not going after people's assets, and that's not the right way to do these sorts of models. If people have saved up and owned a house, you know, they deserve that. They should be rewarded for the work that they have done that way. However, I also met with thousands of people this summer, and people were saying, I've worked my whole life as a PSW. I don't,
PSW?
as a personal support worker.
Okay.
They said, I'm one of the lowest paid health workers, I don't have a pension, and I've worked hard all my life. And I think, honestly, they work harder sometimes than me as a physician, okay? But the idea is, they haven't had the privilege of earning a pension. They haven't been in other situations where they've had to be able to have that. But do I think they deserve the same access to home and community care when they grow old, as opposed to going into a long-term care facility? I think we're a communitarian society, and I think we really need to be providing that care, because frankly, if we say, well, that person, if we say, well, Joe didn't earn that much and he doesn't get much of a pension or anything right now, so you know what the option then is? Joe, if he can't have enough home and community care, he goes into a long-term care bed. And you know who pays for that? All of us do, and that's $47,000 of taxpayer dollars every single year. So you know what? It's about choices, and it's about us helping ourselves and helping each other.
Okay. One of the other choices, I gather, that you are trying to ensure is that every senior in Ontario has his or her own family doctor. Is that possible?
Yeah, absolutely, it is possible.
How do we do that given the financial restraints that we're dealing with now?
So people will get care. It's not a matter of cost, right? It actually may well be less expensive if people have a primary care provider, doctor, or nurse practitioner. So we've got, because we're training more doctors, we're retaining more doctors, we've reversed the brain drain, more doctors are coming to Ontario to practice. We've got more physicians. And what we're saying is, we think we owe it to older Ontarians, to seniors, to have at the bare minimum, a family doctor or nurse practitioner.
Docs don't always want to do that, though, right?
Well, one of the benefits of the recent OMA agreement is that we're actually going to pay doctors more for taking on more complex patients. We've also launched something called Health Links, Community Health Links, and one of the requirements of these Community Health Links is that they do take on seniors in their catchment area, in their geographic area. A few years ago, we made a commitment to people with diabetes. If you want a doctor, we're going to make sure you get one. We've met that commitment. And now I think, there's no question we can do it with seniors. We've got the right levers in place.
Did I read this right? Are you making house calls now?
I've always been making
house calls. You've always made house calls.
Yeah.
Very few doctors make house calls for obvious reasons, because it tends to take too much time and reduces their potential for earning income. Why do you do it?
Well, you know what? First of all, actually, one thing, I was able to get wonderful resources from the Ministry of Health and the other government ministries to do the report. One of the things that shocked me was that across Canada, less and less doctors are actually doing house calls. But actually in Ontario, that's not the story. Over the last 5 years, doctors have been doing more house calls than ever before. In fact, 50% of our physicians in Ontario are actually doing house calls today, 228,000 house calls last year. So the challenge is that how do we make sure that doctors have the support they need, to have the community linkages they need to be able to provide care for these patients. And when you talk about making sure that, so that's been organized in the OMA agreement now. There's a commitment to provide 30,000 more house calls now for those older Ontarians who need them.
She's going to pay you more to make house calls, right? The more house calls you make, the more money you can make in that way, right? There won't be a financial disincentive, in other words.
Exactly. It was about looking again at the agreements, and again, the OMA and the government said, we're going to take less on other areas to make these commitments, stronger commitments. But the other aspect is that one thing that we found was we have community health centers, we have family health teams that actually have capacity to take on more patients. And they were saying to us, well, where are those patients? We also have a system called Healthcare Connect that actually helps connect people, older people who are looking for a primary care provider with one. So we found that there are really clear mechanisms that exist. There are doctors willing and ready to take patients. There are patients who are looking for family doctors, and we have a system to connect them. Part of the recommendations and the support is to make sure that we link that all together so that we can actually guarantee that everybody who wants one, wants a primary care provider, can get one.
But I want, sorry, go ahead.
The other thing I just want to add is it doesn't always have to be a doctor to make that house call. In Samir's model, in his practice, he has other healthcare professionals who make those calls. Doctors do sometimes, but often it's another provider that makes that house call. But they work as a team.
Or something, or
physiotherapists, occupational therapists, social workers. I mean, all incredibly important parts of the team.
I wonder if there is, and I don't know, perversely, could this actually have the opposite effect of what you intend? Namely, if you're a doctor and you make a house call, in that same amount of time that you took to make a house call, you might have been able to see 10 people in your office. So yes, you've given great treatment to one person, but maybe 9 have been disadvantaged. Is that possible?
It won't work that way, and I'll tell you why. And Samir, I'm sure, could add to this. If there are people who are so ill that they cannot get to the doctors, their only alternative now is to call 911 and go to the hospital. We know a lot of people use that service rather than the service of a doctor or other healthcare professional. It actually costs us a lot more.
Sure.
And that is not the best way to care for someone, to take them to the hospital. So we're not paying doctors so much more that they will forego the rest of their practice, and because we are getting to the point where we have, in most of the province, enough doctors to care for the population. Not everywhere, but most places we do, people will still get the care they need.
Okay, in our last 30 seconds here, he's made 169 recommendations. Lots of fun reading there. You can't obviously do it all. What's top priority?
Well, making sure that people do have access to primary care provider, doctor, nurse practitioner is one we've already moved on. There are others that we've already moved on. Getting community support agencies the ability to hire personal support workers to expand access to home care is another one. The most important thing we can do is integrate the system, and that takes us back to community health links, where all of the providers in an area are going to work together, focusing one patient at a time to make sure they get all the care they need in a coordinated way. So that focus on coordination, because currently, a family doctor might not be able to access home care for their patient, so they end up getting inappropriate care. So that coordination, for me, is the biggest challenge we have, but also the most important challenge we must meet.
Gotcha. That's Deb Matthews, the Health Minister of Ontario, and Samir Sinha from Mount Sinai Hospital and the University Health Network. Thanks for visiting us at TVO tonight.
Thank you.
Thank you, Steve.
Support Ontario's public television. Donate at tvo.org.